Well, thank you very much, Shwan, and hopefully everyone can see that. You can see that okay, Shwan?
Yes.
Great. Okay, guys. So we'll get straight into it, and welcome to part 2 of Orthopaedic Oncology. All of the slides that I'm going to show you, I hope, are things that you might see in the FRCS exam. Just a quick plug for the what was the Miller course, now the Oxford Comprehensive Orthopaedic Review course, still scheduled to run face-to-face in January. We'll obviously have to see how that goes over the next few weeks, but whatever happens, the course will run, and it will be great to see as many of you there as possible. Remember, it's one of the few courses that offers a money-back guarantee. So that's the web address. So just to remind you, the origin of sarcoma, we won't spend too long on these kind of sort of embryology slides, but they are important. And sarcoma arises from the mesenchyme. Carcinoma comes from the endoderm. So that's the lining of the inside of the body. So for example, the gut, the lung, etc. But sarcoma arises from the mesenchyme, which is about 75% of your body weight, but surprisingly only about 1% of all of the malignancies. For reasons that we don't understand particularly well, about 60% of sarcomas arise in the lower limb, 15% in the upper limb. And of course, those of you who are on the ball will think, well, what about the remaining 25%? And of course, the answer to that is that sarcoma unusually can occur in any of the body cavities, from within the skull itself to the chest, to the abdomen, so anywhere at all. One of the really nice things about the Oxford Sarcoma Service MDT is that we're one of the few sarcoma services in the world that covers all those different body areas. Not too much histology, you'll be pleased to know, but you could get this in the exam, so it's reasonable to just discuss it very briefly. The 3 main types of tumor that you might expect to see: carcinoma, shown on the left-hand side of the screen, nests of cells, lots of glandular type structures. In the middle of the screen, the hemopoietic tumors with relatively little stroma. So these are things like the lymphomas and the myelomas. And then on the right, the subject mainly of today's discussion, which is sarcoma. And that's that really dense stroma with spindle or cigar-shaped cells, very disorganized and haphazard, with lots of cell bodies. So if the examiner gives you some histology to look at, just be able just to briefly describe and differentiate those, and hopefully that should be straightforward. So wherever you see a red slide, that means it's something important. So think tumor. If you don't think about it, you can't diagnose it. Maintain a high level of suspicion with masses or unusual bone lesions. If it doesn't seem right, it probably isn't, and make a diagnosis. And the guidance from the Royal College now is that all of the candidates should see something to do with tumor at some point during the FRCS, because it's just so important that you don't miss it. This is something you might see in the fracture clinic, something you might see in your general orthopedic clinic, and all of us, no matter where we're working, will see at least 1 or 2 primary bone tumors during our working career. Only this week, we had a referral from one of our district general hospitals that referred to us, where a very experienced surgeon inadvertently has pushed a nail through a high-grade chondrosarcoma. That nail has then pushed all of the disease up into the hip itself, and unfortunately now the patient will need a hip disarticulation. So it can catch any of us. It's caught me before. It will potentially catch any of us in this audience. We just need to really think about it. You saw this X-ray and MRI scan last night. Just the important takeaway point from this is that although this looks the same, these are from 2 different patients, but it just shows you how you can have a soft tissue tumor seen on the left of the screen, abutting the distal femur, and a very similar looking tumor, but a different one. This is a parosteal osteosarcoma shown on the right of the screen. And there are 5 times as many soft tissue tumors as there are primary bone, and that explains the reason why that there are more of the soft tissue units than there are of the primary bone, for which there are only 5. If you got the MRI scan on the left in the exam, you'd be expected to say this is a large soft tissue tumor and it's abutting the periosteum. You can see that there's some periosteal involvement at the posterior aspect of the femur. So you'd really need to be talking here not just about excising the tumor, but about doing a distal femoral resection, but more of that later. So here's just a map. Just be aware of this. It looks nice and slick in the exam if you know where your local tumor unit is, so that you can say you pick up the phone and talk to them. We're shown as the green triangle in the centre here. Obviously, you've got Stanmore in London. That's the Royal National Orthopaedic Hospital. That covers all of the east coast, the southeast, and down to the south coast. We cover the central region right down to Devon and Cornwall. Birmingham, the Royal Orthopaedic Hospital, covering all of the Midlands and as far up as Yorkshire. The Agnes Hunt Hospital here in Oswestry, and then Newcastle covering the north of England. Then there are 2 units up in Scotland, in Glasgow and Edinburgh, and no primary bone tumor units in Wales, so they refer across either to us or largely to Birmingham. The yellow dots are the soft tissue centres. As you can see, many more of those, and just be aware of where you would refer and how you'd get hold of those units. And really, this is what we're trying to avoid. This case here, the tumour is so large that you can barely make out what's the top and the bottom of the body here, the tumour occupying almost the entire thigh. And here, unfortunately, the only option is a hindquarter amputation. Don't get caught with things like this. So this is one that we show the GPs when we're training them. This X-ray on the left, as you can see, looks largely normal, perhaps amazingly normal, but when you look at the MRI scan on the left, there's a huge tumour just abutting the lesser trochanter, which you wouldn't have picked up without cross-sectional imaging. So we really try and show the GPs that this represents the importance, not just of obtaining a simple X-ray, but even just a straightforward ultrasound scan would have picked up this very large mass in the inner thigh. This is the tumour resected. Here in Oxford, we take X-rays of the tumour once they've been resected. It just helps us understand the pathology a little bit better. And again, this was a tumour that was abutting the periosteum, and therefore we needed to do a proximal femoral resection. And these are the delays in diagnosis, really astounding. Osteosarcoma, 16 weeks, Ewing sarcoma, 40 weeks, and pelvic Ewing's 2 years. And only this week in the unit, we've had a 23-year-old girl who's been complaining of groin pain since the start of the pandemic back in March. She's had telephone consultations with her GP. She's been reassured she had a groin strain, and unfortunately she had a large bulky pelvic tumor, and unfortunately she's now got metastatic disease. So it really does emphasize the importance of clinical examination and of imaging, particularly with worrying signs like night pain, systemic symptoms such as sweats and fevers, etc. And why does it matter? Well, this is a really, really important takeaway slide, and this is something you could talk about at the Viva. The 2 graphs show the survival with different sizes of tumour. So if your tumour is less than 5 centimetres at presentation, i.e. the top green graph, then you have an 86% 5-year survival. If your tumour is greater than 50 millimetres at presentation, your survival is dismal. It's down to about 28%. And this was the motivation behind Professor Grimer of Birmingham trying to get the message across that anything larger than a golf ball needs urgent referral. This just shows some of the nations across Europe and where the UK sits in terms of diagnosis. So there's the UK, and unfortunately you can see that we still have relatively late presentation in terms of size at diagnosis. Interestingly, the countries that lie at the very far left-hand side of the screen, so the smallest size at presentation, are the northern European countries such as Finland and Norway, where obesity is relatively uncommon and patients are very aware of tumours at a very early stage. So when should you refer? Just be aware of the referral guidelines. So the Department of Health in 2000 set these down. They said that lesions that are deep to the fascia, bigger than 5 centimeters, are painful, increasing in size, are malignant until proven otherwise. And the GP said, well, that's an awful lot to remember. And so Rob Grimer came up with the easy to remember sort of mnemonic of having a golf ball. And in fact, the GPs were sent out golf balls in the post with the Sarcoma logo on to just have on their desk and to try and prompt them to refer. And we actually say, we've moved on from this, we actually say now that in the hands and the feet, we'd like to see anything larger than a marble. And what we're really trying to avoid is these whoops lesions. These are from 2 different patients. On the left-hand side is a scar that you would never see, you would never make. This is a transverse scar across the buttock. The problem with this scar is that it is non-extensile. So if you need to try and extend this scar, you simply can't. You have to then make a Z-shaped scar to be able to excise this and then enlarge the wound. And on the right-hand side, exactly what we were talking about a few slides ago, patient from the trauma list. You can see this obvious lesion just adjacent to the lesser trochanter. This is an aggressive tumor of the proximal femur, and sadly, the treating surgeon has failed to recognize it and passed the nail down, now taken all of this tumor down into the rest of the femur. And unfortunately, that means that now the patient will have to have, at a minimum, the entire femur taken out and potentially a hip disarticulation. So these are life-changing decisions. These are decisions that any of us could be making on a Saturday or Sunday morning when we're sitting there at the trauma rounds and deciding what we're going to do. But please just really look closely at those x-rays and try and work out if something looks abnormal. So let's think about staging. This is something you could easily get asked about. So know the order of staging studies. And this is a detailed history and a careful physical examination. We're then going to do local staging, systemic staging, and a biopsy. And we're going to talk about the principles of biopsy in this talk. So in terms of local staging, we're going to start with x-rays. So these are plain x-rays taken in 2 orthogonal views. That just means x-rays taken at right angles to each other. And then we're going to use 3-dimensional imaging, and that might be CT scan, MRI scan, potentially both of those, and potentially ultrasound scan as well, to really define the 3D anatomy of the lesion. And then we're going to take a tissue sample in the form of a biopsy. Now, just a common thing that people do get caught out with the use of the bone scan. So remember, the bone scan is very sensitive, but unfortunately not specific. So it's very good at identifying multiple bone lesions. It's very good in the presence of defining metastatic disease. It relies on bone activity and blood flow, but as I'm sure you know, it can be cold in very high flow lesions. So the examiner might say to you, well, why might you, in the case of myeloma or renal cell carcinoma or thyroid, why might you not see a hot spot on the bone scan? And it's simply because those tumors are very, very vascular. The blood is passing through at a very rapid rate past these tumors, and the radioisotope simply doesn't get time to settle for the scanner to pick up that increased activity. So the primary investigation for myeloma is a skeletal survey rather than a bone scan, or actually increasingly, we would simply do a whole body MRI scan to identify what lesions they've got. So the next step in the diagnosis of a patient with suspected myeloma would be serum protein electrophoresis and urine protein electrophoresis, which is Bence-Jones protein. The next step in the staging of a patient with myeloma is a skeletal survey. And when you're looking at that on the slide, that sounds really easy and really obvious. And when you're in the heat of the exam, you've got to really listen to what the examiner is asking for. So are they asking for the next step in terms of the diagnosis or the next step in terms of the staging? And just try and remember and be able to talk about the difference. In this radiograph here, you can see of the left knee that there is a lytic lesion in the left proximal tibia. It's actually fairly extensive in nature. There's the main lesion you can see here, but also working more proximally, and there's cortical erosion. Relatively well defined compared to the surrounding bone, but you also get the suspicion there might be another lesion going on in the fibula, and this would be classic for metastatic disease or for myeloma. Now, what about PET-CT? Well, PET-CT is controversial. It's not used in all of the units. We use it extensively here in Oxford, and I just thought it would be helpful to show you why we think it's particularly useful and why it is increasingly coming in as a tool in terms of systemic staging. So here's a lesion you can see in the axilla for this patient. This is one of our younger patients here. The lesion lies on the lateral chest wall. And the PET scan is really, really helpful for us. Why? Well, because we had assumed from the MRI scan that we might be able to simply resect this soft tissue lesion, but the PET scan highlights to us, which the MRI scan didn't show so obviously, that actually this lesion abuts the second and third ribs. So if you just take this soft tissue lesion out without doing a more extensive resection, unfortunately, this tumor is going to recur again along that intercostal margin. So for this case, this turned out to be a much more extensive case. Here we need the cardiothoracic surgeons to come and provide us with assistance. They will do a controlled pneumothorax, and then we'll take out the entire tumor with those second and third ribs as well. This was a really big team involved in this tumor. We had the plastic surgeons in to help take the tumor away from the brachial plexus, the cardiothoracic surgeons, the orthopedic oncology surgeons, and experts in reconstruction as well. So the PET scan here really helps us define the extent of the lesion. And it's a lovely visual tool for patients as well. Metastatic disease appears as red dots throughout the lungs, which you can show to patients and is very easily understandable. Just remember what's normal. So obviously we'd expect to see tracer activity down in the bladder as this collects, and you'll often see both renal calyces lighting up bright red as well. So if you're not sure, pick up the phone. Get a good history. Think about any prior symptoms. What was the mechanism of injury? Is there any relevant past medical history? What do we mean by that? Well, we mean things like, is there a systemic history of breast cancer, for example, or another malignancy that could have metastasized? Are there any systemic effects from the treatment, such as night sweats or weight loss? Could this be pathological? Could this be a primary metastatic bone tumor? And are there aggressive characteristics on the imaging or presentations? If you don't have the facilities, then refer. All of the units across the UK are ready and willing and able to accept these referrals from the more peripheral units. Now, what about biopsy? You're almost certainly going to get asked about this. So this is a real chance to score a 7 or an 8 in the Viva section. Biopsy is the most important part of staging, and this will be done after all of the local and systemic staging is complete. Most importantly, a poorly placed biopsy site can preclude limb salvage. I'm going to show you some examples of that as we go through. So usually we'll undertake the biopsies in the central units, but occasionally because of geography, or if we think it's likely to be metastatic disease or hematological malignancy, we'll ask the local radiology teams to undertake the biopsy for us. But we'd really like to have that discussion with the referring team, please, before they stick the needle in. So usually we would say the surgeon performing the surgery should be the surgeon to biopsy. This will be based on the definitive surgery, i.e. the definitive surgical approach. As we were saying earlier, we'll use a longitudinal incision so that we can go back and excise or get back in and take more tissue later, and we'll try and avoid contaminating essential structures. Just remember to say that you would always culture what you biopsy and biopsy what you culture. So always be thinking in the back of your mind, could this be infection or one of the great mimics such as fibrous dysplasia or TB? Withhold antibiotics until the cultures are taken. Very careful hemostasis so you don't leak tumor into the wound. You'll do a very careful dissection and closure, and just be aware of the principle of frozen section. So particularly with children where we're not sure of the diagnosis, we will never wake the child up until we've got a definitive diagnosis from the lab, till they're happy we've got adequate tissue and that they can give us a firm diagnosis. Only then will we wake the child up. So surgeon treating, surgeon to biopsy, know the anatomy of the mass, know the procedure that you're likely to undertake. And if you don't know those, then you're likely to have a 2 to 12 times higher complication rate. That's been shown in multiple papers, re-excision following incomplete excision by Davis et al., etc. Lots more recent papers that you'll be aware of. So here's a classic example. This is one of the patients that came to me in our unit. This is a patient with an arm lesion where there was some diagnostic uncertainty. The W that you can see unfortunately links up 5 different biopsy tracks. So there was one here, one here, one here, one here, and one here. 5 different occasions they tried to take a sample of this. And unfortunately, that then means that the whole of that area is contaminated. So before we've even done the operation, we have to take this big paddle of skin away to take away all of the tumor cells. And that then means that that patient will require either a rotational or a free flap to cover the defect. Now, just be able to talk about the difference between FNA, core biopsy, and open biopsy. So let's just spend a few minutes thinking about this in some detail. So FNA is what the breast surgeons love. That's a fine needle aspirate. It's simple, it's quick to perform, and for them, they only have a very limited number of diseases to worry about. All they have to worry about is this a cancer, is this a cyst, or is this something benign like a fibroadenoma? So for them, a fine needle aspirate is absolutely fine and straightforward. You take a sample using a syringe and a green needle, you spray the glass slide with your cells, and then you can look at it very quickly. And the histologist will simply be able to tell you at that point whether there's a malignancy or not. That's all they can tell you. They can't give you a subtype. They can't tell you any of the 80 different types of sarcoma that might be. With a core biopsy, this is where they pass a true cut biopsy into the lesion, usually about 4 to 5 millimeters in size, and the accuracy is much higher, about 85%. And obviously the definitive biopsy is the open biopsy, about 96% accuracy. This is where we have to put the patient to sleep. We'll take a definitive sample of tissue, and then we'll be able to look at it under the microscope. And that gets us a really good diagnosis, but usually we'll withhold that. We can usually get that from as much as we need from the core biopsy. The hazards, well, you can contaminate vital structures with FNA or core. Well, what do we mean by that? That's where, because we're passing a needle or a true cut biopsy into the lesion, unfortunately, there may be a vein or an artery in the way that we don't see on ultrasound, and you can end up seeding tumor into that structure. We avoid transrectal biopsies for sacral or presacral masses. That's because embryologically they come from different cellular lines of tissue, so you can end up contaminating a whole new plane of tissue, which you're trying to avoid. And you must communicate with the radiologist as to where the biopsy should be performed. And in our unit, that means writing it on the form and preferably marking the patient with a permanent marker before they go round to biopsy, so that we know exactly where we're going. And this is the kind of tissue that we might see. So again, a little bit more histology here. Ewing's shown on the left, a small round blue cell tumor, lots of cell bodies, densely packed with relatively little cytoplasm, nuclear pleomorphism, and lots of cellular activity. Myeloma seen in the center, and lymphoma seen to the right. And you could be forgiven for mistaking any of those, but just have an idea about which one you think it might be. And the importance of this is that if you get any of these, then the treatment is going to be, in the first instance, with chemo, radiotherapy rather than surgery, unless of course they've fractured. So I know we've said this before, but just to reiterate, because it's such an important point, FNA is usually used to confirm a diagnosis in an accessible lesion, very rarely used in orthopedic oncology. This is more the case for the dermatologists, the breast surgeons, etc. We usually use core and open biopsy, core to confirm a suspected diagnosis and in difficult locations to access, open if we have diagnostic difficulty in establishing the final diagnosis. You're going to say in the exam that you would excise the biopsy tract, and the logic to this is that when you've done the biopsy, you may have theoretically contaminated the tissues with the tumor. You'll all be aware that there is a paper, at least one paper, there's a very good paper from Stanmore showing that actually there's no clear correlation between excising the biopsy tract and tumor recurrence. But for the purposes of the exam, where possible, you are going to try and excise the biopsy tract with the tumor. It just reduces the risk. Here's our friendly histologist. Not all of them look like this. They don't all look like Father Christmas, but here's a friendly histologist. And in the past, they used to just be able to look down a microscope and tell us what cell type they could see and how malignant they thought it would be. But actually now they've got lots more tools available to them. And there's been a whole explosion in the field of immunohistochemistry, where they can now look at surface antigens for us. They can do cytogenetic analysis to look at different types of translocations. So now in our MDT, they have a whole plethora of information that they can provide us, which even 5 years ago just wasn't available. Just be aware of some of the common chromosomal translocations. It's mainly for those of you who are doing the part 1 of the paper. This is one of those slides just to have a look at the night before. I don't remember most of these. I remember the key ones such as Ewing's and synovial sarcoma. I don't remember most of them, but it makes a really good MCQ or extending matching question. So just be aware of that. And the one to, of course, be aware of, the one that you don't need to know the answer, because none of us know the answer, is that there's no known translocation so far for osteosarcoma. So I think if you're going to remember two, those are the two takeaway ones: Ewing's, peripheral neuroendocrine tumors, and synovial sarcomas. So immunohistochemistry means that pathologists now heavily rely on this for their diagnosis. That's in addition to the morphology. The morphology means the blue and the pink on the slides that we saw earlier. And they'll be now looking for things like gene translocations and other information to give us the final diagnosis. So again, another awful table. The key one really probably from this to remember is S100, which we usually see with the neural tumors, schwannomas, and MPNST, which means malignant peripheral nerve sheath tumors. CD99, commonly seen in Ewing's sarcoma, Vimentin in soft tissue sarcoma. So if you attend any sarcoma MDT, you're very welcome to come to Oxford at any time and attend ours. It's on a Monday morning. Wherever you are, come along, just listen before the exam. It gives you a real eye-opener. And this is the kind of detail that we'll be discussing. So let's move on. Let's talk a little bit about staging. And one of the key things that the Miller textbook does comment on, but I didn't realize for a few years actually, was that the staging systems use the Arabic numerals for benign lesions and the Roman numerals for malignant lesions. So that just, first of all, helps you differentiate between the two. So here we are for the benign lesions, stage 1, 2, and 3. Remember, because they're benign, they're all G0. And they should, therefore, have relatively low metastatic potential. So an example of a benign aggressive primary bone tumor would be giant cell tumor of bone, which has a known metastatic rate of about 8%, but is strictly classed as a benign lesion. The malignant ones are graded G1 low, G2 high, and then they're defined as being intracompartmental or extracompartmental. And then for those stage 3 ones, those are the ones that are likely to have distant disease. This is likely to come up in the Part 1 MCQ or extended matching questions. It's not easy to make a Viva question about this, but I'll just show you one slide that you might want to talk about. And then the Enneking staging system simply defines the degree of extension. So intracompartmental means intraosseous, intraarticular, superficial to the deep fascia, parosseous or within intrafascial compartments. And you can see the comparison with the extracompartmental tumors. And really, this is literally just a case of say what you see. This is just a scientific way of describing what we can see on a CT or an MRI scan. The American Joint Committee on Cancer Staging defines them, and in bone, the key number to remember is 8 centimeters. So that defines whether it's a grade 1 or grade 2, whether there is nodal disease, whether there are skip lesions, and whether it's spread elsewhere. You're not going to be asked to fill in a table like this, but you might be expected to remember the number 8. For soft tissue sarcoma, the number is 5 centimeters. And that was that basis for the Department of Health recommendation, that there was a significant jump in the degree of danger as soon as those lesions became greater than 5 centimeters in size. So every year there's a manual produced by the American Joint Committee on Cancer Staging, and that classifies all of the tumors in all tumor sites. It's worth just having a look at. It should be in your hospital library, and that defines breast tumors, colon tumors, etc. And the examiner might say to you, well, what's the importance of this? And one of the important factors is that it just means we're all talking about the same thing at the same time. And here's the importance of it. Look at this. So this is the overall 5-year survival depending on size of tumor. Stage 1, 98% 5-year survival, down to a dismal 30% survival with stage 4 tumors. So the 3 factors that determine outcome are the size, the grade, and the depth of the tumor. Be able to talk about this slide, hence it gets a red slide. So be able to differentiate between low and high grade. So in high grade tumors, it is relatively undifferentiated, lots of cellular pleomorphism with nuclear atypia, lots of mitotic activity and necrosis. It just looks disordered. But be able to tell the examiner, you can really get a 7 or an 8 on these kind of questions if you're able to define and talk about those kind of slides and how dangerous the tumor looks. What about compartments? Well, just like water, tumor will grow along the path of least resistance. So it will usually try and grow within a compartment, at least initially, but then as it grows larger and it becomes more aggressive, it will spread outside the compartment and it will start to breach the fascia, start to invade the periosteum, and start to invade articular cartilage. That's as it becomes more aggressive. Now, here's that slide I was talking about. You just might want to mention in terms of staging that most osteosarcomas that we see will usually present as a 2B lesion. So fortunately, by the time we get them, usually the chest is clear. There is a degree of extracompartmental extension, but we can usually employ limb salvage and preserve the limb by resecting the tumor. Be able to talk about the different degrees of resection that we undertake. So here's our tumor shown as a blue ball within a compartment. This is the compartment within the thigh. Here's a wide excision. This is the one that you'll invariably use in tumor oncology. So you'll take an adequate margin around the tumor, sometimes including periosteum as well, and send that off to the lab. But if you're really worried about the tumor, if it's very, very high grade, you might decide to be more radical and take away an entire compartment. Obviously, the functional deficit from this is much more significant than if you can do a wide local excision. But what do we mean by a margin? Well, here's one of the cruise ships passing through the Panama Canal. They use sat-nav now to get them through the canals, and we'll just have a few centimeters of margin on either side. And that's these canals, both the Suez and the Panama Canal, by the way, are the reason why cruise ships have never got progressively wider. They've always just got taller, because you can't fit them through these predetermined canals. So a healthy margin is about 2 centimeters. But for example, in the tumor that we were taking out today, in the back of the popliteal fossa, where we were next to both the popliteal artery, the vein, and the tibial nerve, we were probably only able to get a 1 millimeter margin because we were right on those vessels. But a margin is a margin. As long as there's some normal tissue between the tumor and the surrounding structures, then that will provide an adequate margin. But the problem is, the narrower that margin, the smaller the room for error. You just can't afford to make any mistakes if you're that close to the nerves and the vessels. Why are we trying to do all this? Why do we care so much about achieving a margin? Because we're trying to reduce the rate of local recurrence. Here's one of our patients here. You can see he's had a previous resection in the right arm. Unfortunately, the tumor has come back. And what we know is that if the tumor comes back, i.e. locally recurred, then the worry is that it's then got a higher chance of metastatic disease. So that's why we want to try and get it right first time, resect these tumors with a margin, and therefore reduce the risk of metastatic spread. So let's talk about a few of the important soft tissue swellings. These are the ones that I think might reasonably come up in the exam. And we'll just try and give you a few facts to hang like coat hooks that you can talk about them. So these are the ones I think you might see. Malignant fibrous histiocytoma, MFH, liposarcomas, leiomyosarcomas, synovial sarcomas, and myxofibrosarcomas. Let's just talk about a few of those. This is one to really beware of. It's a very common Viva question. The surgeon or the examiner will give you a history of trauma. So they'll try and reassure you, and they'll try and make you think that this is a trauma Viva. So they'll tell you the patient has had a degree of trauma, for example, to the thigh. Patient has a hematoma, and what they want you to say is that you would evacuate the hematoma and then potentially treat the underlying, for example, fracture. But we get really nervous about these hematomas. This is imaging of a sarcoma that's hemorrhaged, and underneath there will be an abnormality. So what we need to do is be very, very wary about these. We biopsy before washout. We may take away some of the hematoma and then sample some of the deeper tissue through a tumor approach, but we will not rest assured that this is just a hematoma until we're absolutely sure. And we've got lots of examples of patients being referred in with really quite significant trauma, which is a red herring. Underneath that hematoma is a sarcoma which has bled into. One of the explanations why they get these hematomas is that the trauma to the sarcoma has made it bleed into that compartment. So remember, soft tissue sarcoma, as we said in the earlier size, bigger than 5 centimeters, high grade and deep is bad. These are tumors that are aggressive and need urgent treatment at a specialist center. They're unlikely to give you this slide, but just to sort of be able to recognize some of the key features that differentiate between the two. In the liposarcoma, you expect to see these lipoblasts, these fat-filled cells occupying much of the space. Malignant fibrous histiocytoma is a much denser tumor with lots of cell body. Synovial sarcoma tends to have this slightly more walling appearance with, again, very dense cell bodies. And leiomyosarcoma a little bit more striated and organized. So tumors are classified according to their origin, so whether they're from fibrous tissue, fatty tissue, that's adipose tissue, muscle tissue, etc. Let's just talk about a few examples. So in terms of the fibrous tumors, we're going to divide those into the benign and the malignant. So benign aggressive, in fact, is fibromatosis, and that is often called Dupuytren's disease of the hand, Lederhosen desmoid in nature. The malignant variation of these is malignant fibrous histiocytoma. This is the commonest malignant soft tissue sarcoma and can occur in any age between usually about 30 and 80 years of age. Let's have a look at some examples. So here's fibromatosis. You'll all have seen this in the outpatient clinics. You get these firm nodules often arising on the sole of the feet or the palm of the hand. They'll be dark on T1 and on T2 imaging. And if you are going to resect these, they do require complete resection with a margin. They've got a very high rate of recurrence. And of course, surgery unfortunately can make the situation even worse. So we treat these very, very carefully. We'll ask for advice from our oncology colleagues as well to see if there's any other treatment options available. Fibrosarcoma, this classic herringbone appearance, this fabric appearance you can see down the bottom with this very organized striated structure, and it literally does look like that under the microscope. The cell bodies arranged in fascial planes with very dense stroma in between the two. The pathology will appear, so the imaging requirement here is the same as for all soft tissue sarcoma, so we get a proper MRI scan, ultrasound, and occasionally we will think about using irradiation in these. Just be able to talk about radiation, so remember the dose is measured in grays, it will be delivered in fractions and avoids damage and dose to surrounding tissues. Typical doses for soft tissue sarcomas are about 180 to 200 grays a day for 5 days a week over 6 weeks. And for tumours that are bigger than 5 centimeters in size, we'll give this neoadjuvantly, in other words, before we take the tumour out. In terms of palliative treatment, we might think about giving treatment for symptomatic metastases. And here are the different doses that we would give. So for metastatic disease, 25 to 30 grays, a higher dose for soft tissue sarcoma. And as you know, which isn't the subject of this talk, for heterotopic bone formation, we might give a very low dose. But the key takeaway point, the point that you need to remember for the exam is that the gold standard for soft tissue sarcomas is usually neoadjuvant radiotherapy. So giving the radiotherapy before the patient goes to surgery and then surgical resection. Now, just remember this slide. It's a really important one that just defines the general approach to these broad classes of tumors. So for osteosarcoma and Ewing's, you're going to give neoadjuvant chemotherapy and then surgery. There's relatively little efficacy of radiotherapy. For chondrosarcoma, you're going to use mainly surgery. Chemotherapy and radiotherapy are relatively ineffective. And for soft tissue sarcoma, you're going to use a combination of radiotherapy and surgery. If you remember one slide from this talk this evening, this is probably the most key slide. These are the treatment strategies that our MDTs will be recommending for these patients. If we think about fatty tissue, this is a wide spectrum, right from the lipoma at the far left of the screen, right across to the dedifferentiated liposarcoma. And we treat these very seriously, particularly the ones that are deep to the deep fascia or within the muscle, so intramuscular. These all need to come out. Here's a classic example taken from clinic. Here's a lesion at the front of the thigh on the right-hand side. This is an intramuscular lipomatous lesion. This is obviously deep to the deep fascia. This is large in size. This needs to come out. So this will have adequate imaging, cross-sectional imaging in the form of MRI scan, be discussed at the MDT, and will then have straightforward surgical resection. This is a more heterogeneous type tumor. This is a low-grade liposarcoma that we can see in the anterior thigh. We'd be more wary of this one, and this one would need to come out with a greater soft tissue margin around it. Here's a classic example of a lesion in the posterior thigh. You can see that the right thigh is much greater in size than on the contralateral side. And here you can see an extensive tumor on the MRI scan, which will require an extensile approach. And here we're just taking the tumor very carefully off the sciatic nerve using a process of epineural dissection to try and preserve function and to take the tumor away with an adequate margin, but to leave the nerve intact. Interestingly, for reasons we don't fully understand, the epineurium around the nerve is relatively resistant to tumor, but only this afternoon, in that case I was telling you about earlier, where we were taking the tumor out of the popliteal fossa, unfortunately we found that the tumor had invaded the tibial nerve, and we therefore had to take away the tibial nerve with the tumor. And these are the kind of bulky tumors that we're talking about. This one here, about 15 centimeters in size. The patient will have often not noticed these for a while as the tumor has slowly grown. And we can see here we've taken away the fascial covering with it to try and maintain this in its integrity. So in terms of differentiating between the two, just be able to talk about the difference between the lipoma and the liposarcoma. And this is really the only lesion that we would resect in terms of the soft tissue tumors without doing a biopsy. The radiologist will confirm the diagnosis to us, and usually we will take these out without undertaking a biopsy. Let's move on. So muscle, again, this is divided into benign and malignant. The malignant forms are the leiomyosarcomas and the rhabdomyosarcomas. These usually involve young patients and again will be treated with chemotherapy and radiotherapy. The pediatric oncologist will get very involved with these and give these youngsters neoadjuvant therapy before we do the definitive surgery. So here's a characteristic one here in a child, the most common of the pediatric soft tissue sarcomas, although it does occur in adults. And unusually, this is one of the soft tissue sarcomas which is very responsive to chemotherapy. So many of the soft tissue sarcomas are not responsive to chemotherapy. This is one just to flag up in your revision that is relatively responsive, and the pediatric oncologist will give that up front. In terms of the blood vessel tumors, these are divided into hemangiomas, which are benign, and angiosarcomas, which are one of the more dangerous of the soft tissue sarcomas in terms of the malignant form. So you've all seen these. This is a common one in a child. They're cutaneous, subcutaneous, or intramuscular. They tend to go up and down, wax and wane in size. We would usually, the plastic surgeon would usually treat these and would usually leave the child alone until they get to a more mature age. And then there are various treatments they can use, such as sclerotherapy, to try and get rid of them. The hemangioma contains mature, thick-walled veins and these cavernous-like vascular spaces. So just be able to recognize the histology. The X-ray may show phleboliths within the soft tissues, and the MRI scan will show a heterogeneous lesion with lots of small vessels and fatty infiltration. And we'll refer these usually off to the vascular interventional radiologists who will be able to sclerose these, usually very successfully. Treatment, therefore, is usually with observation, symptomatic management, or you can consider sclerotherapy. There are the harder variants that just aren't responsive to sclerotherapy. We get one or two of those every month on our lists, which will require surgical resection. But here's the one to worry about. Here's the much more aggressive version of this. This is the angiosarcoma. These are very highly malignant. They metastasize very quickly. They often develop regional lymph node spread, and they can be extremely aggressive. Again, you can get a red herring of trauma here. So the patient will say they've bumped or bashed the area and it's become swollen. We mustn't be fooled by this. This requires urginal cross-sectional imaging, systemic staging, and a tissue diagnosis so we can really understand what we're dealing with. Angiosarcoma does have a higher incidence in terms of chronic vascular stasis in a previous history of trauma, radiation, and lymphedema. So just be aware of this. And the particular example to be able to talk about is Stewart-Traves disease, which we see with breast cancer and chronic lymphedema. The path will show these epithelioid nests, these spindle cells, but back to basics, the treatment will be exactly the same as for soft tissue sarcoma. They'll be worked up with three-dimensional cross-sectional imaging, a tissue diagnosis and discussion at the MDT. Just a mention of some of the common nerve tumours, and the malignant form of this is the malignant peripheral nerve sheath tumour and the very rare neurofibrous sarcoma. Here's one we see relatively commonly. This is a benign lesion, usually occurring on a peripheral nerve, and the radiologist will be able to identify this because it will have this very characteristic eccentric shape with a penumbra on either side, following the line of one of the peripheral nerves. And again, the treatment here will be with surgical resection. These are often quite symptomatic and uncomfortable for patients. The histology will show these nuclear palisading with the verrucae bodies, and they're divided into Antoni A and Antoni B. And we'll try and do a nerve preservation surgery with these, so to peel the lesion away from the nerve, almost like shelling out a lesion from within an onion and surrounding onion skin. The malignant variant of this is the malignant peripheral nerve sheath tumour. These will often occur in patients with neurofibromatosis, so pre-existing neurofibromas. Their imaging will be similar to soft tissue sarcomas, and the tumour follows the nerve. Now, this group of patients is a really good example of where the CT PET scan is really helpful for these. This is an example where a long-standing lesion becomes more painful. You use the PET scan to identify and evaluate it, and it will show that one of these neurofibromas has become very hot, and we become concerned about that and have to resect it. The pathology here will have these spindle cells in a whirling pattern. You can see in the top right, they will be S100 positive on immunohistochemistry, but exactly the same as before. The treatment is the same. We'll do careful surgical resection with a margin, and then carefully look at the pathology, followed by adjuvant therapy as required. Now, synovial sarcoma is worth just a special mention, and the benign version of this is pigmented villonodular synovitis and synovial chondromatosis. The highly malignant form is synovial sarcoma. The new name for PVNS is tenosynovial giant cell tumor, according to the World Health Organization classification. And this is a common one to get in the exam because it's a common one that you could see in your clinics. The knee is a very common site, followed by the hip and the shoulder. It often affects a young population and is divided into nodular and diffuse types. So here's the characteristic MRI appearance of tenosynovial giant cell tumor in the posterior knee. You can see this hyperproliferation around the femoral condyles. It will often spread extensively through the joint. This is with the diffuse type. And in pathology, you'll see these synovial cells with giant cells, histiocytes, and characteristically this hemosiderin staining. And in practical terms, this means that when we look inside the joint, this is one of my patients who had tenosynovial giant cell tumor around the elbow. This is their radial head, and here's this proliferation of tenosynovial giant cell tumor affecting and extending across the joint. We have to do a very surgical resection of this to try and clear all of this away, send it off for pathology. And of course, in this particular location, which you'd highlight to the examiner, you're worried about the posterior interosseous nerve, which will be crossing from anterior to posterior, about 4 centimeters away from the radial neck. You've got to be really careful with this here because this is essentially a benign tumor, but with the potential to cause significant damage here if we damage the nerve. So very careful surgical resection through an extensile approach. So the treatment of this is complete synovectomy. If it's the nodular type, it's a relatively low recurrence, but if it's the diffuse type, recurrence can be up to about 45%. The drug to be aware of is imatinib. This is a monoclonal antibody with the trade name Gleevec, and this does show some promise with the diffuse type of disease. And this will be one of the situations where we'll ask our oncology colleagues just to give us some advice as to whether this might be effective. Synovial chondromatosis is a really important condition to be aware of and just to talk about. This is where you get this proliferation, hundreds and hundreds of popcorn-like nodules throughout and surrounding a joint. And the reason why we have to do an extensive resection of these is that there is the risk of transformation of these into a chondrosarcoma. So we do a really extensive resection. We take away all of these hundreds of nodules. Each one on its own has a very small risk of malignant transformation, but just like familial adenomatous polyposis coli in the bowel, the problem is that the sheer number of them means that any one of them could become malignant. So hence we have to do such an extensive resection. Here's the characteristic MRI scan. This is taken from a shoulder joint. You can see here these nodules both at the front and at the back, this popcorn type calcification, and the treatment for this is an extensive synovectomy and to clear all of that disease. This is what it looks like when it comes out. So lots and lots of marbles in the dish, and the pathologist won't analyze all of those. Obviously, they'll just look at some that look a little bit more abnormal and to see if they can see any dedifferentiation within them. Now, the important takeaway point for synovial sarcoma, so this is the malignant variant of this, is that when this was originally named, it was thought to arise as the primary pathology from the synovium itself, but it's later been found that this is not the case, and actually it's just synovial-like. There are two histological patterns, a monophasic and a biphasic type with the characteristic X18 translocation, but this is one of the really aggressive soft tissue sarcomas. We get very worried about this. This one must be staged early and treated aggressively. It's got a very high chance of malignant spread. The radiographs may be relatively normal. Here's one of our shoulder patients on the right. You can just see this heterogeneity just inferior to the glenoid. Here it just gives us a suspicion of more extensive disease. And here's the histology of it. It's a very aggressive tumor, lots of dedifferentiation here, nuclear pleomorphism and cellular activity. Favorable outcomes, female, they do slightly better in the upper limb. As we've said throughout the talk, less than 5 centimeters with less mitoses per high power field, and they do a little bit better. Just a couple more to go. Epithelioid sarcoma is another one that we worry about. These commonly occur in the palms of the hand and on the forearm. And again, we often see these presenting with a relatively late diagnosis. These will often come on the hands of manual workers, so plumbers, bricklayers, etc. They'll associate it with trauma, but unfortunately, this may represent a very dangerous epithelioid sarcoma, which has a predisposition to metastasize to the lymph nodes. So we commonly see extensive lymphadenopathy up in the axilla and potentially the mediastinum. Really aggressive nodular growth pattern here with mixed polygonal cells with eosinophilic cytoplasm. Just be aware of the great mimickers. So that's lymphoma, myeloma, metastatic disease. Here's lymphoma. The radiographs will often appear relatively normal, but actually when you do the MRI scan, you can see that there's more aggressive disease. The primary treatment here will be chemoradiotherapy unless they've fractured. Here's lymphoma again on the bone scan. The primary treatment here, as we said, will be chemoradiotherapy. If they have fractured, obviously we'll have to intervene, but radiotherapy can be very, very successful in sclerosing these lesions and bulking up the bone. Myeloma, a plasma cell malignancy commonly seen in those over 50 years of age. Again, we'll work them up, as we said at the start of the talk, with serum protein electrophoresis and urine protein electrophoresis for diagnosis. These characteristic atypical plasma cells with eccentric nuclei and eosinophilic nuclei, which we saw earlier. Just a mention of chordoma, which is a midline tumor. It's a malignant tumor of notochordal origin, and it will occur almost exclusively at the top of the spine around the region of C1 and down in the sacrum. MRI will show an expansive midline lesion. These are big cases, difficult cases that we'll often do in conjunction with the spinal surgeons. My colleague Duncan will take these on for the pelvis, and these are really big cases, often requiring a bowel extensoration, the spinal surgeons to preserve the nerve roots, and then to get a margin on those big tumors. The characteristic thing to remember for the exam is that they contain these physalliferous cells, this particular cell type with the bubbly cytoplasm within. And finally, just to remember, always think about metastatic disease. This could come from anywhere, including prostate, thyroid, breast, lung, and kidney. You remember Duncan was mentioning this last night. These are the osteophiles which are attracted to bone. And we'll just finish with this last slide. 5 lesions that can look like anything. Just be aware of these in your differential diagnosis. Fibrous dysplasia, infection. So again, we culture everything that we biopsy everything that we culture. Metastatic disease, the cartilage lesions, and this really unusual one that we won't talk about this evening called Langerhans cell histiocytosis. So remember, guys, the takeaway point is always be suspicious. Anything that you're worried about, get 3-dimensional cross-sectional imaging. If you're concerned, pick up the phone and refer to one of your regional units. Know where that unit will be, and really remember those principles of biopsy that we talked about earlier. Thank you very much.
Thank you, Mr. Kosker. That was an amazing talk, very comprehensive, but also very relevant for the exam. As you said, it is a very common topic in the FRCS exam. We'll first of all move on to the MCQ portion of this talk, and we'll answer any questions from our audience. Okay, guys, if you could please kindly answer. Don't worry, it's all anonymous. We won't know who's answered what. Just while you're doing that, I'll just remind you that OR UK and FRCS Mentor Group are working in conjunction to provide these talks to you. We're both charities. Both of us are focused on education, but OR UK is also focused on a significant amount of research and helping in assessing orthopedic conditions and moving them forward. If you visit the ork.org website, you can find lots of courses. Some of the courses that are coming up is the Tuesday foot and ankle Viva session, which is going to be on Tuesday evening, 20th of October. They've also got a couple of observer places on Tuesday the 13th and Wednesday the 14th. These are evening mock Viva online webinar type scenarios. And of course, there's other courses there as well. Please do take advantage. The FRCS Mentor Network is, if you go to frcsmentor.co.uk, you can find our courses there. The ones that are coming up are the FRCS Viva Practice, 10th of October, 24th of October, 21st of November. I believe 10th of October is full now, and there's only 1 or 2 places left for the 24th of October, but we have some places still for the 21st of November. Of course, you know, on a Wednesday, we do this webinar session regularly, and we do have Viva sessions during this. Also, you can take advantage of going over our historic or previous YouTube on the YouTube channels, and also any OR UK webinars on their website as well. And a final reminder to Tom Kosker, thank you so much. And the Miller course I found incredibly useful, and I would really put a shout out for anyone who would like to join. Hopefully it will still be Viva, which means the NHS hasn't collapsed, but if it's not, I'm sure it will be online. Have we got the results of the MCQ?
Yeah, I apologize. I've realized looking at question 1, I missed out a word, so I'm going to take either CT of the area involved or CT chest here. It's my mistake. It should have been systemic staging of a patient with sarcoma after the chest X-ray. So yeah, I totally agree. You would want some cross-section imaging of the lesion itself. But the point of the question was really that you can't rely on the chest X-ray to make sure there's no metastatic disease. You need some cross-section imaging of the chest. Sarcoma will almost exclusively metastasize to the chest. So hence you need a CT chest scan. But apologies for the missing word. Characteristic translocation for synovial sarcoma, you've just got to know that one. It's X18. And you all got the question at the bottom right just about, which is great news. The benign aggressive tumor that we talked about at the start of the talk, but does have metastatic potential, giant cell tumor of bone. Hence, we follow these patients up for at least 5 years, if not 10, with regular chest imaging. I think we're joined by my colleague Shah now, Mr. Whitwell, who's back on the line, I think.
Yes, I think he is with us.
Yeah, hi, Tom.
Thank you. It's great that both of you are here. Thank you for staying. There are a few questions. Nikki, if you don't mind asking. Mr. Koster, I do appreciate that you have...
Yeah, I'm sure I've got to peel off, but I'll leave my colleague Duncan Whitwell on the line if that's okay.
That is brilliant. Thank you so much for the talk.
Thank you.
Thank you so much for your time. Hi, Mr. Whitwell. Thank you for joining us again. Our audience from yesterday would recognize Mr. Whitwell. He'll answer some of the questions that Mr. Koster has begged from the audience, and then we can move on to doing a few quick Bible sessions. Again, I know Mr. Whitwell has time commitments as well, so we won't take him too long.
Okay, so there's not as many this evening, as I think we've had some help in the chat. So I've got a question from Christopher Jenkins, who said, can you clarify the difference between a hip disarticulation and a hindquarter amputation, and what determines the choice between these?
Yeah, so a hindquarter amputation involves the pelvis. So it will probably largely be up through the sacroiliac joint. So you take the whole pelvis out and the lower leg, and then you probably either have an anterior or posterior flap that you reconstructed. A hip disarticulation is you keep the pelvis and you're actually just cutting through the hip joint. And yeah, the decision is depending on where the tumor is and to make sure you've got a margin. What you can't do is do a massive amputation like this and not get a margin. So you have to get above it to some degree. The trouble about a hindquarter is that you don't have an ischium then to sit on. So they do find it quite challenging. And they often maybe do need an orthosis to actually allow them to sit on, because they've got the ischium on the other side and they fall over a little bit on where the hindquarter is. So sometimes we do an operation where we actually salvage the distal femur, and we keep the distal femur supplied by the femoral artery and vein, and we bring the distal femur up and attach it onto the sacrum. And then the distal femur, the knee joint, is then the ischium for them to sit on, so they can sit comfortably. And eventually we've given a hindquarter to give them what is like a through hip amputation.
Great. Thank you. I've got a question from Herb, who says, what are the clear indications to request a PET CT for tumour?
Well, we probably do it on almost everyone, including the benign aggressive tumours such as giant cell tumour, because it really does show in about 10 to 20% of cases disease that otherwise you probably wouldn't see. It shows very good response to treatment. But unfortunately, it's a little bit more expensive. Not all hospitals have it. But in Oxford, I would say that probably every patient gets a PET CT scan with a benign aggressive or a malignant diagnosis. Other units use it less and maybe not so much. They would maybe use just bone scans and chest CT scans. But we find it an invaluable. And there are papers on there showing the efficacy and the usefulness in sarcoma. So I think going forward, it's going to be the standard for systemic staging of patients with benign aggressive or sarcoma.
Thank you. Got a question from Suleiman Yunus. Regarding the posterior approach to the femur, can you excise the sciatic nerve if the tumour has invaded the nerve?
You'd have to, wouldn't you? I think this balance. This is what makes sarcoma surgery quite interesting, because you've got to do this balance between function and oncological resection. And I think Tom talked to you a little bit about, can you get away in some tumors with a marginal margin, do you have to do a wide margin? And as I talked yesterday in my talk, there are tumors such as enchondromas and low-grade chondrosarcomas that you might be able to treat with a curettage, which is intralesional. So yeah, the bottom line is that you can have a limb salvage surgery and you can sacrifice either the femoral or the sciatic nerve. I think that the limb isn't really worthwhile saving if you have to sacrifice both nerves. But yeah, you can get away with a reasonable leg if you do have to sacrifice the sciatic nerve. You'll get a foot drop, but that can be treated with a splint. You'll have a slightly insensate foot, so you've got to be a little bit careful about pressure sores. But yeah, patients probably do better with their own leg than with an amputation.
Thank you. And then a question from Omar Ahmed. What about pexidartinib in PVNS?
I haven't heard about that actually, but that's one of the nibs. These are some of the new biological therapies that are making big inroads into treating some of our cases. I think that normally the PVNS is the nodular variety, which can just normally safely be treated with surgical resection. It's a diffuse type. This is a type where you've got little soft tissue lesions here, you've got bone erosions there, they're not joined. It is a PVNS and you've got to try and get it all out, and it's just impossible to, because it's diffuse everywhere. And if there's a new type of biological therapy to try and control the spread of this disease and the erosion into bone with rank ligand inhibitors, absolutely fantastic. But I've got no experience with that at the moment. But yeah, it's good news that there maybe are some other agents online.
Okay, this one, I think we answered this one last night, but this is from AJ. If known primary and no Mets previously, present with pathological fracture, then fix or stage it first. If it's isolated Mets, can it be salvageable?
I think we did have that, and
yeah.
It's the fact that I tried to sort of give the scenario that in a busy trauma clinic or busy on call, you know, sometimes you cut corners and you sometimes say, right, I'm going to take this patient to theatre and we'll send the femoral head, say, off to the laboratory afterwards. For the exam, I think the rules are, if there is no history of metastatic skeletal metastasis, you have to assume that any new lytic lesion that you come across is a primary malignant bone tumor until proven otherwise. So even if they've got history in the past, but they've got no known history of metastasis, you've still got to be thinking that's a sarcoma and appropriately staged them, not rush them to the operating theatre and just say, I'll send the reamings off to the laboratory and see what happens. Sit tight and do the proper staging as Tom explained today.
Great, thanks. And I think this is the last question from Amma Sate. What is the ideal preservative fixed fib material for histopathological sample? And would it be the same material if we suspect infection? My understanding was infection was a fresh sample.
Absolutely, yeah. So yeah, we do try and sort of send both microbiology and histology. The key thing I think maybe from Tom's talk is that if you're doing an open biopsy, you have to get a frozen section before you close the patient up and wake the patient up, because there's nothing worse than having an open biopsy and finding that you have got an incomplete sample. So you don't get the diagnosis from the histologist, but all the histologist will tell you is that you have lesional tissue, and he can then make a diagnosis on it. And that will be fresh, like microbiology. But yeah, if we're taking a tumor out, it just goes get put in formalin and then gets transferred to the laboratory for workup the next day sometime.
Great, thank you. I think that's all the questions.